Baruchim Abayim, and a big welcome to all our guests tonight. Before we begin, I would just like to run through with you the order of the evening and give you some technical tips on how to make the best of it. My name is Jay Churara from the Jewish Community Foundation Trust, and I will be your host for this Salford Healthy Communities event tonight. You may have noticed that everyone is muted. Please stay muted, as the sound is very sensitive on these microphones. If you wish to comment or ask a question, please do so on the chat function. Our speakers, when invited to speak, will need to unmute themselves. The event itself is being recorded and a public record made available for those who are not present with us tonight, so that they can also benefit. You can turn off your cameras if you wish. Dear audience, we are exceedingly privileged to have with us this evening a distinguished guest consultant, Dr. Angela Paisley, our guest speaker, who will share with us the latest developments and updates on how to prevent developing diabetes and also answer your questions. So I will introduce our guest, who will give a presentation. We will take questions with Dr. Paisley, and Dr. Jackie Lewis will talk to us about diet in relation to diabetes, and we'll make some concluding remarks. We aim to finish around 9:30 tonight. Before we start, here are just a few words of introduction for Dr. Paisley. Dr. Angela Paisley has been a consultant in diabetes and endocrinology at Salford Royal NHS Foundation Trust since 2012, and is the lead for the diabetes service in Salford. Dr. Paisley manages patients with both type 1 and type 2 diabetes, and also undertakes specialist clinics, i.e. pre-pregnancy planning clinics for people with diabetes. Dr. Paisley has also been involved with trials for managing patients with impaired glucose regulation, pre-diabetes, and helped set up the impaired glucose regulation service in Salford. So without further ado, Dr. Paisley, over to you.
Thank you very much for that. And thank you for inviting me to speak. It's a great pleasure to be able to come and speak to you all. I have got some slides, but really more as a prompt. So for people who are on their phone, you're not missing out by not seeing any slides. I haven't got anything fancy on them. It's just a few words, really. So I'm just going to share my screen. So please let me know so this should now be visible to those who have got the screen. Okay. So I'm actually going to talk first a little bit about type 2 diabetes, because obviously it's important to be aware of type 2 diabetes and the problems associated with it to understand why it's important to try and prevent developing type 2 diabetes. It just helps with the understanding. So I'll focus first of all on diabetes, and then I'll talk a little bit afterwards about patients who are high risk for diabetes and what they can do to prevent going on to develop diabetes. So as you've already been told, I'm a consultant in diabetes and endocrinology at Salford Royal, and I lead the diabetes service and predominantly do diabetes there. Now, Okay, so that should have changed now. So as you'll all be aware, diabetes is increasingly prevalent, and it is becoming more and more common and more of a problem. And this isn't just in the UK, this is worldwide. But currently in the UK, nearly 5 million people are diagnosed with, have diabetes, but around 850,000 of those are actually undiagnosed. So there's a significant number of people out there walking around with diabetes who aren't even aware that they've got it. It's a problem because it's associated with significant morbidity and mortality. So patients are at risk of other medical problems and of early mortality when it's not managed appropriately. It also is costly. So it accounts for 5% of the total NHS resources, and 10% of the hospital inpatient resources are spent on patients with diabetes. But what's particularly worrying is that it's thought that around 13.6 million people in the UK are currently at high risk of going on to develop type 2 diabetes. So it's only going to become more of a problem as we go forward. So what is diabetes? Well, diabetes is when your blood sugar, or glucose as it's known, is too high in the blood. And there are two main types. There's type 1 diabetes, which is the less common type, and around 10% of patients with diabetes have type 1. And then there's type 2 diabetes, which is the more common type, which is related to weight and lifestyle. And around 90% of patients have type 2 diabetes. There are some rarer genetic forms which are far less common. But it's type 2 diabetes that we're going to focus on tonight. And this is the type that's increasing in prevalence, really due to our lifestyle, because we tend to have more of a sedentary lifestyle and we have more problems with obesity than ever before. So in terms of diabetes, how does this work? Well, it's the carbohydrates that we eat that are converted into glucose in the body. So that's all the beige foods, things like pasta, bread, chips, potatoes, and rice. And when we eat those foods, they're digested and converted into glucose in our body. So we eat and our blood glucose goes up. And in response to that, our pancreas produces the hormone insulin to help us deal with that sugar. And the insulin basically works a bit like a key. So it opens up the cells, allowing the glucose to pass from the bloodstream and into the cells in the muscles and the brain and everywhere in the body, so that we can use that to provide energy. And by doing that, it lowers the blood glucose levels. And diabetes occurs when something in this pathway goes wrong. So I mentioned previously that there are two types. So type 1 diabetes, which is the rarer form, accounting for around 10% of patients, is due to what's known as an autoimmune destruction of the pancreas cells. And that's where, for some reason, cells in the person's own body have turned against the pancreas and destroyed the cells. And so because of this, the pancreas can no longer produce any insulin at all. So patients with type 1 diabetes have to take insulin injections for the rest of their life. And insulin is necessary to live, so they can't ever have a day off and omit their insulin because they're at risk of becoming very poorly and dying if they stop their insulin altogether. And type 1 diabetes has absolutely nothing to do with what you eat or your weight. It's like a completely different condition. Type 2 diabetes is due to insulin resistance. So what that means is that the insulin isn't working properly in the body. So patients eat and their blood glucose goes up and their body produces insulin in response to help them handle that sugar. But because they're resistant to the insulin, it doesn't do its job very well and the blood glucose stays high. And so because of that, the pancreas then tries to produce more and more insulin to do its action. And eventually the pancreas tires out and can't quite produce enough insulin. And that's when patients tend to tip over and develop diabetes. Now, type 2 diabetes is actually a progressive condition because over time, if the pancreas is needing to work harder and harder, over time, it can't continue to produce all that insulin. And so it wears out and produces less and less. And that's why most people, if they've had type 2 diabetes for long enough, will end up on insulin injections. Now, there are risk factors for type 2 diabetes, and some of them we can't do anything about. So there's definitely a genetic risk. So if you have a family history in a first-degree relative, then you're up to 6 times more likely to develop type 2 diabetes. So this might be your parents or your siblings, and equally a child. If a child has type 2 diabetes, even though you might be older, you're at increased risk of developing it. Age is a factor. So for white people, once you're over the age of 40, that's an increased risk factor. Whereas for certain populations, for example, South Asians and Afro-Caribbeans, who have an increased prevalence of type 2 diabetes, they're more at risk over the age of 25. Gender plays a part, with men slightly at increased risk. And for women, if they have a history of gestational diabetes, which is where they developed diabetes in pregnancy, but it went away again after, they're at increased risk of going on to develop type 2 diabetes later in life. There's also another condition that affects females called polycystic ovarian syndrome, and that's also associated with insulin resistance and type 2 diabetes. So all of those factors can't really be modified, but there are certain modifiable factors that predispose the risk for type 2 diabetes. And the main one is weight. So generally as a society, because of fast food, less activity, just generally in society, people are heavier than they were many years ago. And weight does play a factor, because if you are overweight, that increases your insulin resistance. And that's particularly if you've got more fat tissue around your middle. You'll be more insulin resistant and more likely to go on and develop type 2 diabetes. So diet is key in helping you reduce your risk. So a healthy diet is essential. But activity also plays a part, and that's because exercise improves your insulin sensitivity and makes you less resistant to insulin. So the more activity you do, again, the lower your risk will be of going on to develop type 2 diabetes. And in this country, it's quite hard, isn't it? We've got awful weather, so who wants to go out walking in the winter? And as a result, we have a more sedentary lifestyle. You might also have a job where you're sedentary all day long. But again, all those factors increase your risk. So that's something to think about, how you can increase your walking or any activity, going to the gym, whatever it might be that you feel you can do. There's something called the metabolic syndrome, which is where patients have high blood pressure and high cholesterol levels. That also increases your risk. And smoking and alcohol also play a part. So healthy living is really important in reducing the risk. So if you think about risk factors for type 2 diabetes, then it'll come as no surprise that the first sort of approach to managing type 2 diabetes has to be looking at lifestyle. So I think what's key in patients who are diagnosed with diabetes is that they're given appropriate education. So they need to understand about diabetes and how the food affects their glucose levels, and learn how to eat healthily. So obviously any healthy diet, reduction in fat, reduction in unhealthy snacks, but in particular, it's the carbohydrates that are converted into glucose in the body. So it's thinking about the carbohydrate portions and the sizes that we eat. And again, generally as a society, our carbohydrate portions are far too big. So actually the dietitians that I work with will tell patients that a normal portion size of carbohydrates is 2 spoonfuls. Well, if you think about a meal of pasta, we all load our plates up, and very few of us would only have 2 tablespoons of pasta. But actually a normal portion size is only very small. So eating healthily is key. And also, as I mentioned before, keeping active, thinking about what activity you can do. And it might just be getting around the house more, doing a bit more housework, going up and down the stairs. It might be going out for a walk regularly each day, or you might be able to do more exercise, going for runs or going to the gym if you can do that. And by eating healthily and keeping active, that will help with weight loss. And it's the weight loss that's key, because if you can lose some weight, that reduces your resistance to the insulin. So you respond better to the insulin that the pancreas is producing, and that controls your blood sugar levels better. And we know that if patients can lose 5% of their weight loss, that dramatically reduces their risk of going on to develop type 2 diabetes. But equally, once they have diabetes, if they can lose the weight, that itself can push diabetes into remission, meaning that the patient can bring their blood glucose levels back into the normal range. Now, sometimes lifestyle modifications aren't enough, and so then medication is needed. And we've got various different treatments. We've got newer tablets, which are really fantastic at helping control diabetes, and obviously injectables as well, insulin, but also other therapies. And I've not gone into detail about the medications, but I'm happy to answer any questions after. But where lifestyle modifications aren't enough, we then recommend medication, because what we don't want is patients to continue with very poor control of diabetes and high sugars, because that's stressing their pancreas more and means that their diabetes is going to progress much quicker. So we don't leave patients for long times. What we do is we give patients a few months to try lifestyle, and if it's not enough, then we might consider introducing medications at that point. So why does it matter? Why do we need to control diabetes and make sure the blood glucose levels are in the right range? Well, that's because if the glucose levels are left high, it leads to furring up of the vessels and atherosclerosis. So that leads to cardiovascular disease. And this, in fact, is the main cause of death in patients with diabetes. So around a third of patients with diabetes will have cardiovascular disease, and around half of patients will actually die because of cardiovascular disease. So it can lead to problems in the heart with ischemic heart disease and heart attacks. It can affect the blood vessels going to the brain, so patients are more likely to have strokes. It can also affect the blood supply to the eyes, so patients can have problems with their vision and in fact lose their vision altogether if it's not dealt with appropriately. It can affect the blood supply to the feet and also the nerves to the feet. And if these are impaired, this can lead to foot ulcers. And the problem with foot ulcers is that creates a nice open wound for bacteria to enter, an infection. And that can then spread into the bone if it's not managed appropriately, and can lead to amputations. Diabetes can also affect the blood supply to kidneys, so people can get kidney damage. And if that progresses to kidney failure, patients can need what's known as dialysis, which is like an artificial kidney to do the work for them, which they need regularly each week. So it's really important that patients with diabetes achieve good, steady glucose levels each day in the target range, because we know that if they achieve that, we can prevent complications. And I have many patients in my clinic who are in their 80s and 90s with absolutely no complications because they've managed their diabetes well over the years with good glucose levels, and they don't have complications. So along with this, compliance is key, really. So it's really important to try and stick to a healthy diet, but it's also important to try and make sure that if you are on any medications, that you're taking them regularly and looking after yourself to achieve good diabetes control. And that's for two reasons. I've mentioned to prevent the complications, but as I also alluded to earlier, type 2 diabetes does progress with time. And this will happen much quicker if your diabetes isn't well controlled. Because if your glucose levels are high, then you're stressing the pancreas and it's needing to work a lot harder to churn out more and more insulin. And so it tires out much more quickly. And so you will need insulin far sooner. Whereas people who achieve good, who are able to manage their diabetes well, adhere to a healthy lifestyle, maybe lose some weight. If they are on medication, make sure that they're really complying and taking it regularly. This will stave off the need for insulin for many years. So compliance is key. I just also want to mention the importance of annual screening processes for patients who do have diabetes. So as I mentioned earlier, the main sort of risk in diabetes is cardiovascular disease. So patients should have an annual screen to look at all those cardiovascular risk factors. So that's things like their weight, looking at patients' weight, blood pressure, is it on target or not? And the targets are tighter in patients with diabetes. And if it's high, it's thinking about things like taking less salt in the diet, but also some people might need medication for their blood pressure, and it's important to take that and make sure it's well controlled. Because if it's not, it adds more pressure on the heart and the kidneys and the eyes. So again, that increases the risk of going on to develop complications. Cholesterol levels are measured as well each year to make sure that they're on target. And obviously, if they're high, we'd be recommending a healthy diet with less fat. But also, the patients with diabetes all will end up on statins, which is the tablet for cholesterol. And the reason I say that is there's very, very good evidence. There were huge studies done years ago in patients with diabetes, and they looked at all patients with diabetes, those who had good cholesterol and those who had bad cholesterol levels, or high cholesterol, I should say, to start with. And they gave everyone a statin. And what it showed was no matter what your cholesterol was to start with, even if you had a good cholesterol to start with, it halved your future risk of heart attacks and strokes. So there's really good evidence that statins are beneficial in patients with diabetes. And diet is really good, but diet can only do so much. And there is definitely a genetic risk as well. And some people can't achieve target cholesterol levels without additional medication. We also look at smoking, because obviously if you're smoking, that also increases your cardiovascular disease risk. As well as that, we measure patients' kidney function each year because of the risk to the kidneys. And we also ask for a urine test. And the reason for that is to measure the protein in the urine. And that's because an early sign that the diabetes is affecting the kidneys is that they start to leak protein. And that happens before the kidney function itself has been affected. So before we would see any abnormality in the blood test. So it's really important that you have a urine test as part of your annual review. We also check the eyes, check that you're up to date with eye screening, because if there are any diabetes changes in the eyes, unfortunately, you don't know about them. You don't lose your vision until very late on. So it's important to have that check each year so that if there are any diabetes changes, they can be dealt with promptly so that they don't go on to affect your vision. And we also check patients' feet. We check their pulses in their feet and the sensation to make sure that they've not lost the sensation or got poor blood supply that would increase their risk of going on to develop foot ulcers and problems with their feet. So in terms of long-term management for those with diabetes, the diagnosis of diabetes is for life. So it is important that you do look after yourself if you're diagnosed with type 2 diabetes. It does tend to progress, but as I say, you can prevent that or certainly delay it progressing by, again, looking after yourself and making sure it's as managed as well as it can be. And it's important to make sure that you have your annual review processes done each year. And compliance is essential. And if there's one thing I would say, it's when you have your diabetes checkup, be honest. So if you're not taking your tablets, that's okay, but admit it to the doctor you're seeing or the nurse. There's no point sort of pretending that you're taking them. Often as doctors, we can tell if patients are taking their tablets or not. And it's much better for patients to be honest. And then we can explore why you're not taking them, see if there's any alternatives that might be better. And at least it's a more honest consultation so that you get more out of the consultation. But can we prevent it? Well, yes, we can. So we have patients with diabetes, and then we have patients who have completely normal glucose levels. And in between, there's a category called pre-diabetes, or it's also known as impaired glucose regulation. And this is the intermediate category. where patients who fall into this category, we know are at increased risk of progressing to develop type 2 diabetes. And around half of people with pre-diabetes can prevent the onset or certainly delay its onset by changing their diet, losing some weight and increasing their physical activity. And we know that if they can achieve 5% of their, if they can lose 5% of their body weight, this will significantly reduce their risk. So over the last few years, there's been quite a move to try and identify patients who are in this high-risk group to see if we can intervene and prevent them going on to develop type 2 diabetes. So the same risk factors as before apply. People who are at risk for type 2 diabetes, so in the white population, it tends to be those over the age of 40. Weight is an important factor. So if you have a BMI of over 30, then you fall into the obese category, and that increases your risk. If you have other conditions, so for example, cardiovascular disease, high blood pressure, if you've had a stroke, polycystic ovaries, if you've had diabetes in pregnancy, and also mental health problems are associated with type 2 diabetes. The condition itself, but also some of the medication that's used can increase the risk. So it's important to be aware of that because you might fall into that category. Family history, as I mentioned before, because of the increased genetic risk. And also steroids increase your risk of diabetes. So if you have asthma or COPD from smoking and you have courses of steroids, that might increase your risk. So there's various ways to find out if you've got a high risk. So if you fall into any of those categories that I've mentioned, then you should really be getting a check to see if you might have pre-diabetes or even diabetes. And there's various ways to do this. So you could see your GP, and this is probably the most, I say it's straightforward. It's not the most straightforward nowadays because obviously it's difficult to see GPs with the increase in demand following COVID. There are other ways as well. So pharmacists, opticians, there are NHS walk-in centres and dental surgeries who can all help you to assess your risk. You can also go online. So there are various self-assessment tools that you can look at to look at your risk. So Diabetes UK have a page on their website where you can do a risk score to see if you score highly. And the NHS have a health check programme again where you can go online and look at your risk. And if you are a high-risk patient, if you fall into a high-risk category, then the next step would be to do a blood test to see if you do in fact have pre-diabetes. And generally what's measured is the HbA1c, which is actually what we measure in patients with diabetes. And this is an average of your blood sugar control over the last 3 months. And there's a certain category, if it falls between 42 and 47, then that would indicate that you're of high risk to going on to develop type 2 diabetes. So a HbA1c of 48 and above means that you have diabetes. And if it's between 42 and 47, then you fall into the high risk category. A fasting glucose can also be measured to look at your risk as well. But it tends to be HbA1c nowadays that patients get measured. And if it's found that you fall into that category, then there's various programs that have been set up to provide education and support to help you reduce this risk so that you sort of reverse that risk back into the normal glucose range. So there's an NHS prevention program called Healthier You, and this provides education and support in terms of promoting exercise, helping you lose weight, and educating you on a healthy diet. So if you're high risk, it's recommended that you do take up one of these programs. If you're found to be low risk, then the guidance is that you have your risk assessed every 3 to 5 years. So just a bit more about the NHS Diabetes Prevention Programme. So this really has been set up to provide tailored, personalised support to reduce the risk of type 2 diabetes. It's a free 9-month programme where there's an initial one-to-one assessment with a health and wellbeing coach to assess your risk and your health and well-being. and to understand your needs and motivations and program goals. It provides education on how to prevent type 2 diabetes, and there's the opportunity for group discussions and also ask your coach sessions, which can all be done remotely from home. There is also a one-to-one digital option. And topics covered include nutrition guidance and support, but also advice on physical activity and strategies and tools to empower the long-term progress. And then at the end of the program, there's a one-to-one review with a health and wellbeing coach where they'll hopefully celebrate your achievements, consolidate your learning and set post-program goals. So that's the program set up by the NHS, but there are other programs and other ways of addressing your risk. In Salford, there's also a program called Aviva, and this is where you're matched with a personal health coach or a community group, and there's one-to-one dedicated dietitian and psychological support to help you achieve a healthier weight and adopt lifelong healthy habits. And this is done on the phone or by use of an app to guide you. And the app tracks your progress and provides resources, including videos, podcasts, and recipes. So just a little mention on diabetes and COVID. Going back to those in pre-diabetes, I haven't really gone into detail about diet, and I know that Jackie's going to talk a bit more about that after, but obviously I'm happy to take any questions as well at the end. So just with COVID being so topical, obviously we've all had a terrible time the last couple of years with COVID. And for those with diabetes, it's important to be aware that this does increase your risk of developing a more serious COVID illness if you are to contract COVID. And it's very much related to your control of diabetes. So the higher your HbA1c, so in other words, the higher your glucose levels are day to day, the more at risk you are of becoming more poorly from COVID. And the more at risk you are of developing complications. And also your body mass index is also associated with more severe COVID. So if you're heavier BMI, again, that also increases your risk of severe COVID illness. So I think if you have diabetes, from the point of view of COVID, it's important to address your diabetes and maybe see your healthcare professional to see how to improve it. And what is also key is that because you are at increased risk, I would recommend that you take up the vaccine and make sure you're up to date with your boosters. And certainly working in the hospital, the patients who are on intensive care currently are the ones that haven't taken up the boosters and are at very high risk. Whereas those who've had the vaccine, it definitely does protect you. So be sensible and look after yourself and address your diabetes and make sure you're being sensible going forward. I also just want to mention diabetes and pregnancy, just because having diabetes does increase the risk of pregnancy. So it's important to be aware of this because it's important to have good diabetes control before you even get pregnant. And that's because obviously, if you get pregnant, as a woman, you don't even know you're pregnant for the first few weeks. But in that first few weeks, the baby is developing. And so if in that time your glucose levels are high, this increases the risk of miscarriage, but also of the baby's development going wrong. So it increases the risk of congenital abnormalities. And it also seems to have this programming effect on the placenta later on during the pregnancy, in that it's more likely to fail. And if the placenta fails, that can increase the risk of stillbirth and the baby dying. So it's really important that if anyone has type 2 diabetes and they're thinking of pregnancy, that they get some appropriate advice. And certainly at Salford, I run a pre-pregnancy planning clinic, and I would urge people to come and see me, ideally about 12 months before they even want to start trying to get pregnant, because it can take a while to get your diabetes to the right level. And the levels recommended for pregnancy are tighter than we would recommend outside pregnancy. Because of the increased risk of congenital abnormalities and spinal tube defects, it's also recommended that you take a higher dose of folic acid. So anyone, whether they have diabetes or not, it's recommended that they take folic acid prior to conceiving. But in diabetes, it's recommended that you have a higher dose, and this needs prescribing by your GP. We would also look at other tablets that you're on. So for example, some people with diabetes might be on blood pressure tablets or statins, which might not be safe in pregnancy. And so we would also switch you to safer agents in that pre-pregnancy planning clinic. So I just wanted to mention that in case that applies to anyone on this session. If you are thinking about pregnancy, do get a referral to your local pre-pregnancy service. So just to conclude, I think going forward, what's really important is that you know your risk. So if you don't have diabetes, think about whether you are in that high risk category. And if you are, go and see your GP or do an online assessment or go into a walk-in centre and find out if you do fall into that high risk category, because then you should be going on to have a blood test and see if you fall into the pre-diabetes range. And if you do, you can then take action to prevent or delay its onset. And the treatment for this, the management of pre-diabetes, also applies for those with diabetes. So exercise is key. Physical activity helps reduce your risk and also helps in the management of diabetes, maintaining a healthy weight and eating healthily. So that's all I was going to say tonight. I'm happy to take some questions either now or at the end, whatever you want. And I hope that was appropriate for everyone. I didn't want to go into too much detail because I appreciate that obviously a lot of people on the session won't have diabetes. So that's why I've not gone into too much detail, but I am happy to answer questions.
Dr. Paisley, thank you very much for your informative and really illuminating talk and meaningful explanations on a subject that is very much of concern to all of us. Everyone was there listening attentively. We do have some questions that have come through, and then I will ask a couple of questions that have come through, and then we will open it up to the audience where they can raise their virtual hand, and then they will ask the questions themselves. Talking of diabetes, and we did mention that one of the triggers and the prompts to begin to do something about it is falling into the category of high risk, and you went through the list of that with us. So the question is, and I'm sure you did allude to it, as well as that, would looking at the symptoms be another way to do that, such as increased thirst and so on and so forth? And what are the symptoms?
So yes, the problem is that if you're in the pre-diabetes range, you probably haven't got any symptoms, because it's only once the blood glucose levels are going quite high that you're developing symptoms. So if you're getting symptoms, that's because you're more likely, you probably got diabetes and you're not in the pre-diabetes range. But for those, and I suppose there might be some who actually have diabetes and who are not aware, the symptoms of having high glucose levels are fatigue. Now, obviously, that's quite a non-specific symptom, but those specific to the high glucose levels are feeling very thirsty with a dry mouth and needing to wee a lot. And that's because when your blood sugar levels are high, that filters out, the excess sugar also filters out into the urine. So you wee out more of the sugar and it draws water with it, so you become dehydrated. So as I say, the main symptoms if your sugars are high are feeling very thirsty, very dry mouth and needing to wee a lot. But unfortunately, a lot of patients who are high risk for diabetes don't fall into that category, and so are probably not getting any symptoms altogether, which is why it's important to think of those other risk factors as to why you might be high risk.
Indeed. Thank you for that, Dr. Paisley. I am a psychologist, and I do tend to look at things from a psychological viewpoint. And you did mention the whole package of exercise, relaxation, and diet, and so on, to begin to look, especially when it comes to chronic conditions. I also look at the social and cultural factors that we have in our community, and one of which is this need to conform in terms of eating, and when eating out and conforming and eating with others. And many of us tend to, that is when they tend to, you know, the diet goes out of the window and so on. And is there anything there that you could add to that?
So I think what's hard about diets is sticking to it all the time. And I think it's thinking more about healthy eating long term. So no one is going to be able to, you know, have a completely healthy diet every single meal every day. And everyone has to have some time off when they go out for a meal, but it's just trying to be sensible. And if you're feeling full, don't force yourself to eat everything on the plate. And also thinking about the types of food you eat. So it is very much the carbohydrates that are converted into glucose. So it's thinking about the carbohydrate portion. So I tell my patients with diabetes, and particularly during pregnancy, where again, it's very important to have very tight control, when you're having your food, when you think about your plate and putting the food on, halve your carbohydrate portion size and have more of the healthier foods. So have more of the salad or the vegetables and the meat and protein, but less of the carbohydrate, because that will help with your diabetes and help control your blood glucose levels. I think it's really just thinking about being sensible. And again, you know, no matter which culture, no matter which religion, everyone, food is a big part of it, isn't it? You know, people get together, it might be your Friday night, Sabbath, it might be a Sunday lunch for, you know, Christians, but every religion has times when they celebrate with food. And what I'd say is think about trying to be more sensible again there, not loading your plate up with loads, huge, big portions, and just trying to be a bit more sensible. So it's not that you can't eat any of the food, it's trying to be more sensible about the amount you're eating, I would say. But also long term, day to day, thinking about what sort of food you like that's healthier as well. So what's more sustainable going forward, because if it's a completely dramatic diet, you might not be able to stick to it. Whereas actually what's more realistic is to think about how you can amend your diet to something that you still like, because you've still got to enjoy food, it's still a part of life. So it's thinking about the healthier options that you might like. And again, as I say, portion size is key.
So, thank you very much for that, Dr. Paisley. Yes, I agree, diet is very important, and we will hear shortly from Dr. Jackie Lewis on that topic itself. I will now open it up to questions from our audience. If anyone wishes to ask a question directly, please raise your hand and you will be unmuted.
I have actually seen there are some questions in the chat. Do you want me to go through those?
I think Dr. Jackie Lewis has been answering some of those questions, but yes, indeed. There is another question while we wait for our audience to come through. This whole area, and you did touch on it, Doctor, this whole area of risk factors from side effects of medications, whether be for treating mental health issues or other diseases. How important is this, and is there anything that we can do to mitigate those effects?
Do you mean just generally in terms of medication having side effects?
And in particular with regards to diabetes, yes. Yeah.
So I mean, every tablet comes with a long list of side effects, but it doesn't necessarily mean that you will develop them. And I think a lot of patients worry that they will develop these side effects, and they read it all and then, you know, and spend a lot of time worrying about it. But actually, when trials are done for drugs, anything that's mentioned during that trial has to be listed. So it doesn't really necessarily mean that there's a high risk of going on to develop that side effect. And they do tend to categorize it on the patient, on the labels. And I think what's important to understand is why you're on that medication and what the benefit is. Because if you don't understand that, then you're never really going to want to take the medication. But there's really good evidence for the tablets we use in diabetes in terms of improving the diabetes, but also preventing the complications and helping to reverse them as well in some instances. And so I think it's a matter of trying the medication. What if you've got to discuss it with your healthcare professional, know why it's being recommended and why you're going on it, and then trying it. If you experience side effects, which some people will do with some medication, go back to your healthcare professional and mention that, because there's other ones we can try. So for example, statins, the side effects tend to be dose dependent. So the higher dose you're on, the more likely you are to get side effects. But then we could change to a different one, which we could use at a lower dose. So, and equally with blood pressure tablets, there's so many out there that if you get side effects with one tablet, we can try a different one. So it's just being honest, really, and sort of letting your healthcare professional know that you've had problems with it, and then discussing with them if there's something else that you might be able to try. But really, it's a matter of trying the medication, because some people do get side effects, some people don't, but you don't know unless you try it.
Indeed. Thank you for that. That was really a comprehensive answer. One more question before we invite Dr. Jackie Lewis to address the topic of diets. Is there, with all the advances that we're making in medicine and technology and artificial intelligence and so on, is there a prospect of a cure along the horizon for diabetes, short of a pancreas transplant, that kind of thing?
So the problem in type 2 diabetes is that you can transplant the pancreas, but that doesn't alter the disease itself, because the problem is that generally if patients are overweight, that makes them resistant to the insulin. And so that will, if a patient remains overweight, they will remain resistant to the insulin. So all that will happen is that then that will start to stress out the new pancreas that's being given, and they will end up with diabetes again. So it's not a cure. And pancreas transplants aren't done for patients with type 2 diabetes for that reason. And they are used in type 1 diabetes, but that's because it's a completely different pathogenesis. The cause of the disease is very different. But in type 2 diabetes, there isn't a cure in terms of pancreas transplant, but you can cause it to go into remission. You can get it into remission yourself by addressing, your healthy lifestyle, your diet, your weight. And that's why it's important to try and get patients as early as possible on that trajectory to reverse the risk as early as possible before they ever go on to develop type 2 diabetes. But even those with type 2 diabetes can reverse it back into the normal range and go into remission with the right management.
That is amazing. It almost sounds miraculous that it can be done. Thank you very much for that, Dr. Paisley. Unless anyone has any questions that they would like to put to Dr. Paisley, please raise your hands. We will now ask Dr. Jackie Lewis.
I think there are a couple of hands up.
Right, okay. My apologies, I couldn't see them. Right, yes, we have Tanya Nelson. Yeah. Please unmute yourself and go.
Thank you. Dr. Paisley, thank you very much. That was very informative. It's a lot of information that I'm familiar with because I've just recently been on the education program, which you're probably involved with, which was extremely helpful for anybody who is of type 2 and hasn't been on it. I would recommend it. It's at Salford Royal, and they've been fabulous. I've also got a health advisor who's phoning me on a monthly basis, and we're working on goals together. So that's been really, really helpful. I was interested to hear about the side effects of medication, because mine is type 2 steroid induced, unfortunately. And because I actually managed to reverse my pre-diabetes, but then because of my health, my respiratory disease, I've been on very high steroids. And so I became type 2, which was I think, expected by all concerned. Now it's been suggested I now have to go on statins. So my concern is, with the combination of the steroids and the statins, what's that likely to do to the type 2 diabetes?
So the commonest side effect. Do you want to mute again so it doesn't go on?
Yeah.
So the commonest side effect with statins that people generally hear about is muscle aches and pains. The majority of patients who I have on statins don't have any problem, but some people do have problems with muscle aches. And what we generally do is just switch to another agent, because it doesn't apply with all agents. So I think steroids themselves do increase your risk of diabetes, and you've obviously experienced that. And obviously, if you need your steroids, there's nothing you can do about that. But if you've been pushed into the diabetes range, no matter what the cause is, you want to make sure your diabetes is managed as well as possible to reduce your cardiovascular risk. And so I would recommend that you go on statins because they help to reduce your cardiovascular risk. And as I say, statins generally are well tolerated. I know they've got bad press. Certain articles in certain newspapers have given them bad press, but actually a lot of that is false. So be careful what you read. In terms of the data out there, there is far more data showing the benefits of statins than any problems. And as I say, the majority of people who I have on statins don't have any problem at all. So I think try it. You would only be started on a low dose anyway. That's the same with all medication. You know, for people with diabetes, they tend to be started on the lowest dose, and then it's often built up. Try it. If you develop side effects, go and see your GP or whoever's prescribing it, and then and discuss it with them.
Thank you for that. Carl Montlake.
Thank you, Jay. Doctor, I just ask you a couple of link questions, really. I'm fortunate that I don't have diabetes, and I do lead a reasonable, healthy lifestyle, exercise every day. But what I can't get to grips with is this body mass thing that you doctors seem to go on about. I weightlift. So obviously you're weightlifting, you expand, your muscles expand, and all the rest of it, and your body gets bigger. And yet they say that you become overweight because of your body mass, and quite often you're turned away from treatment if you happen to go to some related illness because of your body mass. Could you clarify that for me? And second, I had cancer a few years ago, and can that have a knock-on effect to diabetes, the cancer that I had?
So in terms of the body mass index, the reason we use that is because it's a better assessment of patients' weight, if you like, than just using the weight itself, because patients might be very tall, and it accounts for that. And so it just gives a better assessment of the amount of fat tissue there. It's still a bit crude, and there are better ways of assessing fat mass, and that would be better in someone like you say. If you tend to, so if someone weightlifts, they're going to be heavier because they've got more muscle mass, which weighs more. Yeah. But it's the sort of best assessment we've got when you just turn up in clinic. It's better than just doing weight alone because it gives a better guide. But there are, as I said, there are more accurate ways of assessing fat mass in the body, but they might be more invasive, or they're not so easy to do. And so yes, there are a couple of caveats for those who've got high muscle mass, and we'll often, if we're reviewing a patient, we would take that into account. But generally, it's quite a good guide for most people. And then with regards to cancer, so cancer can increase your risk in terms of often the treatment for cancer can involve high-dose steroids. So some people find that they develop diabetes because they've had high-dose steroids during cancer. But again, those patients have probably already got a predisposition to developing type 2 diabetes later in life anyway. But there certainly is an increased risk because of that. In In terms of other risk of cancers, generally not. I mean, it depends what type and things, but generally it's not a huge risk for going on to develop type 2 diabetes. It's more sort of medication that would be the risk.
Thank you, Doctor, for that. Thank you for the clarity.
Thank you very much, Carl, and thank you very much, Doctor, for that comprehensive overview and for answering all our questions. I'm just checking if there are any more hands. If anyone is waiting to ask a question. In that case, I will now invite Dr. Jackie Lewis to give us an address.
Thank you so much, Jay. And if there's anyone who has had questions in the chat box that we haven't had a chance to answer yet, please let Jay know or repost your question if you feel that it's been missed. I do apologize. Thank you so much, Dr. Paisley. What a fantastic talk. I'll do the full vote of thanks at the end, however. So people won't be surprised when I say that I feel that diet is crucial in helping to prevent diabetes, or Dr. Paisley said it's key, but she also said it can only do so much. I think it can do a great deal. Nowadays, it's being shown that the vast majority of people with pre-diabetes can actually turn it around, as more is known about how your diet can help. And there's a Dr. David Unwin, he's a GP based not far from here in Southport, and he is achieving 92% reversal of pre-diabetes with his patients, and about 54% of patients who've got recent onset type 2 diabetes, he's managing to turn it around. He is a very charismatic doctor who puts a huge amount of input into his patients, but even so, it's really heartening to know that these things can be achieved. There are different ways that one can help with diet, such as very low calorie. There are soup and shake diets, there's low carb, there's fasting diets. Personally, I tend to favor a mixture of Mediterranean diet, which is about lots of fruit and veg, oily fish, olive oil, etc., together with reduced starchy carbohydrates. It's a bit of a tongue twister, that reduced starchy carbohydrates, and some intermittent fasting. But could I just try to do my screen share, Jay?
Yeah.
Let's try that. So if somebody is actually on medication for diabetes and they make significant changes to the diet, and it's really crucial that they speak to the doctor, because medications may need to be reduced. Some may even need to be stopped. That's just a little bit of a safety message. Let me turn that off again. So some people think that preventing diabetes is all about sugar, and certainly reducing sugar is very important. Sugar is one of the main risk factors for developing diabetes if you're regularly having lots of sugar in your diet. Obviously, most people know about sugar in obvious places like jam, marmalade, honey. A lot of people think honey's okay because it's got some good things going for it, but it is still sugar, so try not to have too much. But most of the sugar that you get in your diet is from processed foods or places you don't expect it to be. Things like soups, sauces, even in bread, even in things like smoked salmon. So just a few of you will have seen my sugar demonstrations before, but very quickly. So a bottle of Coca-Cola or other similar drinks has a massive amount of sugar in it. Jay, can you see that clearly?
Yes, that's very good.
So that's very scary, because you'd never, if you had a child with you, you'd never spoon sugar into their drink like that. But people might give a child a Coca-Cola or some similar drink and not realize the harm they're doing there. As I said, sauces and soups are bad. And this one is a teriyaki sauce. And I looked at that and I thought, oh, it says only 2.5 teaspoons. But then I realized that that's 2.5 teaspoons per tablespoon. So a shop-bought teriyaki sauce might be a bit like pouring syrup over your dinner. It's almost completely sugar. And this one is not dissimilar. That's a sweet chili sauce. And that one's got 43 grams of sugar per 100 grams. So it's nearly half sugar. This one, I'm trying to cover the makeup because it's a common kosher make of cake. But I call these type of things factory cake because it's got so many additives, but it's a quarter sugar. So 3 small slices will have 7 spoons of sugar, which is an adult's total daily allowance. But also, I was looking today, and it's got emulsifiers, it's got raising agents, it's got preservatives, it's got E-numbers, and these things can also be harmful for risk of developing diabetes. You just don't want too many processed foods in the diet, which is why I talk about factory bread and factory cake, because preserved foods can be so harmful. So getting used to looking at labels can be really good. And really, I'd say only if you buy shop-bought foods, only buy the things where the label has a green for sugar content, because the amber, you would think it might be okay, but that can go up to about 5 spoonfuls of sugar per portion, which is just crazy. If you stick within the green, what you want is less than 1 teaspoon of sugar per 100 gram. 1 teaspoon is 4 gram. So 4 gram is a really useful number to have in your head if you're looking at labels. So sugar contributes to weight gain, and weight gain contributes to belly fat. And again, many people who've seen me speak before are familiar with this awful thing, which it represents 5 pounds of fat. It would be okay if the fat just went under your skin, if it was just subcutaneous, but when you put weight on, most of the fat tends to unfortunately go to the belly. I call it kugel belly, but unfortunately it squeezes around the internal organs, around the liver and pancreas and heart. And when it's squeezing around the pancreas, then that's really putting one at risk of diabetes. So what can you do to reduce this visceral fat, this dangerous fat that's in around the internal organs, to reduce your risk of diabetes? And there's a lady, Professor Iris Shai of Ben Gurion University of the Negev, and she's done a load of work on this topic. And she has shown that to reduce visceral fat, firstly, there's things you want to reduce. Obviously, sugar in the diet, as I explained, pop of any kind. Alcohol, minimizing alcohol is crucial to reduce belly fat, absolutely crucial. And processed foods. And also, as Dr. Paisley was explaining, starchy carbohydrates. So the bread, rice, pasta, potatoes, which that is the basis of a low carb diet, reducing bread, rice, pasta, and potatoes. There are other good carbohydrates in the diet, including most leafy green vegetables, and fruits tend to have a fair amount of carbohydrate, but it's those starchy carbohydrates that cause the issue. But there are things that are good, things you can eat that are really good. And these include fiber, oily fish, fermented foods, things like yogurt and kefir, all fruit and vegetables. Well, sorry, when I say all, with the fruits, you want to try and minimize the tropical fruits, the really sugary ones. Even grapes and bananas can have issues, and dried fruits similarly. But the other side of the scale with fruits, the better ones are your berries, your apples, your oranges. Those are fabulous and are high in antioxidants. Antioxidants are another thing that's good for reducing your visceral fat. So if you like green tea, if you like herbs and spices, and those are really fabulous for you. Go for fresh food, consider fasting, and exercise, and all these things help visceral fat. So let me just do another screen share if I may, Jay.
Yeah.
Sorry, I need to move it on, but. Oops, I'm not sure. I've not been familiar with using this PowerPoint. I do apologize if I can't move it. Never mind, I shall abandon that, but I can tell you anyway. So I wanted to tell you all about an experiment I did on myself very quickly. I wore a continuous glucose monitor for a couple of weeks to see what the effect would be of starchy carbs on my blood sugars. And I found that a bagel put my sugar to 8.4. Now, ideally, most of the time, I should be running blood sugars around about 5, 6, that kind of thing. I don't have diabetes. I don't expect to be getting high blood sugars. But a single bagel took my blood sugar to 8.4. 2 slices of challah took it to 7.9. A slice of matzah to 7.7. Matzah, people think that that's fine, but it is still made of flour. Well, sorry, of matzah meal. It's still a starchy carbohydrate. It's still a starchy carbohydrate. And then the other thing was a jacket potato, large jacket potato, 8.9. So it just demonstrates that if you can cut down on these starchy carbohydrates, if you can really minimize them, you have a really good chance of getting good blood sugars. The other kind of foods I had were things like cheese, melanzane, which is an aubergine and cheese and tomato dish. I had omelette, I had nuts, I had eggs, all of these kind of foods, and the effect on blood sugar was minimum, absolutely minimum. Whereas the starchy carbohydrates were pushing my blood sugars up. And in the second week of me eating all these really sugary foods to see what would happen, I found that I was getting worse and worse blood sugars. So in the course of 2 weeks of unhealthy eating, my metabolism had changed. I maybe was getting into the pre-diabetic kind of spectrum already. If I'd kept going for long, I might have become diabetic. But the good news about that is by going back to healthy eating, to cutting down on the sugar and all these starchy carbohydrates and all the processed foods, you can have the opposite effect. Your metabolism can improve really quickly. So a patient of mine did just that. He cut back on carbohydrates, he minimized sugar in his diet, he exercised more. And the main change he made was that he used to, for his lunch, regularly get a baguette sandwich. And instead he swapped to having a salad. That was a simple change for him. He found that he lost that visceral fat. His visceral fat levels went from high to normal. He was virtually diabetic. He was just on the brink of diabetes, but his blood sugars completely normalized. He feels energized. He sleeps better. He's lost his large belly and he's just absolutely thrilled. And one technique he has, he told me, is that when he's eating out with friends and there's too much food, he slips a bit of extra food to his dog under the table. So it can work. He will still always have a tendency to diabetes. He will always need to be careful with what he eats and continue to exercise. But if he keeps doing what he's doing, then he's not going to suffer any of the ill effects that Dr. Paisley was describing, and he's not going to have to go on more and more medications. It's almost a choice, which is more important to you. Do you want that increased vigor and health, or do you want to continue eating the way you've always eaten, but maybe put yourself at risk of worsening health? So on the basis of this, might you really cut back? Might you really cut back on sweet foods and pastries, and only have them maybe at Shabbos, and even then not to lose control? Might you drink mostly tea, coffee and water, maybe some fruit teas, but little else, certainly not going for those fizzy pops, because even things like a diet cola does count as ultra processed and has got lots of chemicals in that can slowly put one at risk. Might you cut right back on starchy carbohydrates, and as Dr. Paisley described, only have just a little bit of rice or pasta or 2 or 3 small new potatoes at the side of your plate? I describe it like, don't have a bed of rice, have a little pillow of rice, have a tiny bit on the side on your plate. Or other people have described it as squeezing out the carbs on your plate. So have more of the veg, have more sauce, but make sure there's no sugar in that sauce. Have maybe more of the protein, but very little of the starch. Plenty of fruit and veg, not much nosh. Might you consider having an apple or salad or soup before a meal, before an evening meal, so that you're less hungry, less likely to overeat? And might you occasionally do a mini fast? And that might be as simple as having an early evening meal and a late breakfast or no breakfast. Only do this if you find it reasonably easy to do. Don't want you doing mini fasts if you're prone to fainting or if you're pregnant, and I don't want children doing it either, but it can be helpful to improve your insulin sensitivity. So lastly, just some resources, and I did put them at the head of the chat box, but there's a good website, diabetes.co.uk. There's a book I always recommend, Reverse Type 2 Diabetes by David Cavan, or the Diabetes Weight Loss Cookbook by Giancarlo and Katie Caldesi. And David Unwin wrote an incredible introduction to that, but a warning is that the recipes in there, they're not kosher recipes, you'd have to adapt them. And lastly, a really good book is Carbs and Cows, Carb and Cal Counter by crischiette and yellow bololia. And there's two actually. There's also the Carbs and Cows World Foods. The advantage of the latter one is that it actually includes diagrams of how many sugar cube equivalents there are to certain foods, which can be a real eye-opener. So thank you very much. Back to you, Jay.
Okay. Thank you for that, Dr. Jackie Lewis. That was really fascinating to listen to, and I'm sure I, like others in the audience, were taking notes and already thinking of making some changes to our diet. Before we do the vote of thanks for Dr. Paisley, I wanted to give our audience an occasion to ask questions on what we've just heard, if they wish. Anyone would like to do that? We have Rabbi Saunders.
Hi, thanks, Jay. Thanks, Dr. Paisley. Thanks, Dr. Lewis. I just want to make two comments. Sorry, there seems to be some sort of interference there. Say two things. Firstly, my wife, who's not in this evening because she's attending our granddaughter's show, pre-Purim show, so she's out. But she actually was diagnosed probably about 3 or 4 years ago now with the onset of type 2 diabetes, and her GP gave her the option if she wanted. He's actually quite reluctant, but she persuaded him to give her, I don't know, 3 months, whatever it was, to see if she could reverse it. And she did something called the keto diet, which cuts out a lot of carbohydrates. And she did this really religiously, and she lost quite a lot of weight. Not sure exactly how much, and even if I did, probably wouldn't say it publicly, but she lost an awful lot of weight, and she went back to the doctor, and he congratulated her and said, yes, you've managed to reverse your diabetes. And she's actually kept it up since then. She's been really religious with it. The only possible downside, she doesn't agree that it was a byproduct of it, I'm not so sure, is unfortunately last year she had problems with the gallbladder and had to have that out because it became inflamed. So I think that could have been a side effect of the diet, but I'm not sure. But she really did well. The other thing I want to say, Jackie, if I may, you mentioned matzah, and then you said matzah is made of matzah meal. If I can just point out, actually it's the other way around. Matzah meal is crushed matzah, which is used for baking instead of flour on Pesach or before Pesach. Matzah itself, religiously, is made out of flour and water, but is done in such a way that it doesn't rise, so there's certainly no yeast, nor is there any other ingredients such as eggs, unless it's egg matzah, but there's no eggs, salt, sugar, or anything else that you put in bread. It really is strictly flour and water, and it is worked on in such a way, obviously without yeast, that it does not rise. So you're quite right, matzah is essentially flour. Just, I suppose, not the same amount as bread, but it is flour and water. Thanks.
Thank you for that, Rabbi. If anyone want to come back on that, either Dr. Paisley or Dr. Jackie.
Go on, Dr. Paisley, sorry.
Yeah, no, yeah, I mean, the keto diet is basically a very low carb diet. So essentially, instead, the patient's eating the protein, but it can also be higher in fat content. So that might have precipitated the gallstones. So that certainly could be linked. I think patients will find their own diet, and what's more important is that can they stick to it, because often patients will do an extreme diet, but then when they stop it, then it all reverses and the weight comes back on. But she's obviously been able to sustain the weight loss, which is fantastic. So well done to her. It's not necessarily the healthiest long term, because the high fat can increase the cholesterol. But I don't know if she's eating healthily, then great. And at the end of the day, from the low carb point of view, that will certainly reduce the diabetes risk. And which is obviously what she's done. She's reversed it. So that's good from that point of view. Jackie, do you want to comment on the diet?
Thank you. Yes, absolutely. Keto is a stricter version of a low carb diet, and it can be very effective. So with Dr. Unwin, for example, with his patients, most of them go on low carb, but if they're not achieving the target weight, then he might suggest they try keto instead. And total cholesterol can go up, but other lipid markers like triglycerides tend to go down. And in fact, there's been one study called Foresight study, if anyone wants to look it up, where they looked at people in the setting of a low carb diet. It is possible to have more saturated fat without so much effect on cholesterol as one might expect. I don't know what you think, Dr. Paisley, but to me, if you can prevent diabetes and all the risks of heart disease and other complications that go with it, then that, to me, almost trumps anything else. And I've known a lot, I know from Dr. Unwin's work that he finds that quite a lot of patients can actually reduce their cholesterol medication and reduce their blood pressure medication. I didn't mention that before. So people who are going quite strictly low carb might, if they're feeling dizzy, they might need to be getting their blood pressures monitored in case they're dropping and they need less medication. I don't know what your view is on that, though.
Yeah. So I think in terms of the diet, I think it's just whatever works for each person. And I don't really have a problem as long as it's effective. You know, it's whatever works. And yes, if it's working, no matter which diet it is, if you start to lose weight, then that alone will help to improve your cholesterol profile and your blood pressure. So yes, medications might need reducing. And so it's important to get that monitored, particularly if you're getting side effects and feeling dizzy. It might be that you don't need as much blood pressure medication. So yes, that's an important thing to think about.
Thank you. Jay, are there other questions?
Yes, thank you very much. I'm just looking at chat here and a couple of comments that have come through. One that says that my husband and I went on that diet and he has reverse type 2 diabetes. Another question that asks, is kosher bread the same as what Dr. Lewis calls factory bread? That's what we have here on the chat.
So regarding the reversing, I mean, to me, this is why I've gone into the nutrition side of things, because I just find it so exciting to be able to help reverse people's pre-diabetes or sometimes even the type 2 diabetes. It's a fantastic thing, but if one achieves that, there's always going to be that tendency in the future for it to come back unless you stick with the diet and unless you maintain the exercise. So people who have achieved this should still get regular blood tests, maybe annually with the GP or 6 monthly if they're willing, but at least annually. It can be a really good way of keeping you on track, because if the blood sugars are starting to deteriorate, then people just get the drive they need to tighten up again on the diet and get it right. From point of view of kosher bread, obviously there's lots of different types of kosher bread, and fresh homemade kosher bread I wouldn't class as factory bread at all. Wholemeal is better than white refined bread, but even the best wholemeal bread can still put blood sugars up. So if one's eating a lot of wholemeal bread or wholemeal pasta or brown rice, far better than the white versions, than the refined versions, but can still put blood sugars up, meaning that one then starts getting a lot of raised insulin. And everybody should remember that insulin is a fat storage hormone. So if you're constantly getting a lot of high blood sugar and so a lot of high insulin, and you're going to be locking the fat in the fat cells, making it much harder to lose weight. So really try to reduce the sugar and starchy carbs.
Thank you.
Anything else on questions?
Thank you. I can't see any more questions coming through. This is really a fascinating topic. We have Tanya. Tanya has her hand. Tanya.
Yeah, a question for Dr. Paisley. Jackie also mentioned in the levels of experiments. Very interesting, Jackie. I think I didn't realize how much sugar was in bagels. I was told, because of the when I monitor my sugar level, my glucose level, Dr. Paisley, that being on steroids, because that increases the glucose, it wouldn't be, it would be a higher level expected. That, you know, sort of, it wouldn't be sort of the 4 to 5 area. It would be more like 9 to 10. That would be acceptable. I wouldn't need to worry about changing my medication, increasing my medication if it was that level. Is that right? I was told that at my annual, at my review recently.
No, it's not right. At the end of the day, yeah, you want good diabetes, you know, control all the time. If you go on a course of steroids, you will have higher glucose levels during that course, but it's only for a short time, and then you'll come off them and your levels will go back down.
I'm on permanent steroids.
Oh, okay. So no, because at the end of the day, if your glucose levels are higher, then that will translate to a higher HbA1c. That will mean that when you next have your HbA1c, it will be higher and above target, and that's all putting you at increased risk of cardiovascular disease. So your target is the same, no matter whether you're on steroids or not. You still want to make sure your diabetes control is as good as it can be and on target.
And what should that be when I monitor it?
So, well, it depends. When you're first diagnosed, and we'd aim for it to be less than 48 millimoles. So 48 is the cutoff for diabetes, and you're aiming to get it less than 48. But if you're on more agents, so once you're on, you know, 2 or 3 agents for diabetes, then we aim for it to be aiming for it to be less than 53, certainly less than 58, so sort of low 50s. But yes, it's just slightly less.
If I was monitoring my daily consumption, like Jackie was referring to, how much, you know, when she was monitoring herself, her glucose level that particular day, not the blood, not the HbA1c, but her glucose level that day, that's what I'm referring to. So she's saying how much, you know, the result was with a bagel, with matzah, etc., etc. That's what I'm referring to. What would
So
be
sort of 4
daily amount?
Sort of 4 to 6, 4 to 7 pre-meals.
Right. Right. So which
you're
is less
still
than I was told.
And, yeah,
right.
You
A
know,
lot less than I was told.
Yeah.
So between 4 and 6.
Yeah, or 4 to 7 pre-meal.
4 to 7. If it was above that, then consistently, I should really speak to my GP.
Yeah.
About. I mean, I'm on metformin. I'm on 4 a day, and that was changed to I think it's the slow releasing one because of the side effects I was having. But hopefully, I'll reduce some on biological treatment for my condition. So hopefully, the idea is to stabilize the diabetes and also reduce the steroids. So hopefully that will you know, sort of improve things. Jackie, coming up to a bit alarmed when I heard about matzah, because there is not much else to eat Pesach time. You want to have a snack, but you know, I was quite surprised when you said how much was in matzah.
Yes,
coming into Pesach.
And I feel embarrassed that I said that matzah was made of matzah meal rather than of flour and water. But I think what can one do at Pesach? Only really not have everything with matzah.
Right.
Have more vegetables, fruit, protein, and small amounts of matzah. The tendency at Pesach is to just squeeze matzah into every
Snack on it.
thing and snack on it, but it does still send blood sugars high, as with any other starchy
Even as
carbohydrate.
matzah meal, it's still, you know, it still counts for not flour, but you know, it's just unleavened flour, really, basically. But it's still, you know, a carb.
It is.
Whichever way you look at it, you know, it's a carb.
Yes.
Right. Thanks. Thank you, Dr. Paisley.
Thank you, Tanya. I don't see any more hands up. I think we really could go on listening to this information all night because it's so useful, and I'm sure, like me, perhaps you would want to, and we will make the recording available for everyone. You would want to listen to this again, just to make sure that we have all the useful information at hand when we want it. I will now turn to Dr. Jackie Lewis for the for concluding remarks and a vote of thanks before we end this evening.
Just quickly, Jay, I was asked in the chat, how do people access the recording afterwards?
We will make it available via a link, and then I will send a copy to yourself, and it will be available on the YouTube channel for everyone else with links available there for them to look at.
So if they go on YouTube, what do they actually look for?
They will be looking for the either words such as Salford Healthy Communities, okay, and for the date when the event took place, and it will be there, or the JCFT TV, which is the channel where it will be available. But we will make all that information available for people so that they have it at hand.
Thank you so much. So I'm delighted to have the opportunity to thank Dr. Paisley so much for your kindness in joining us tonight, for your expertise, the clear way you've described such a complex topic, and just you pitched the level of the explanation, I think, just ideally for us. So many times one gets a consultant and they just give the same old talk that they would give maybe to a medical audience, and it's not what people need to hear, whereas what you've told us is what we need to hear tonight. So thank you so much. I think the talk's been useful for everyone, and I'm extremely grateful. A particular phrase you said was that you ask people what the foods are they like to eat that are healthier, and try and have more of those. And that's just such great advice. And it's something I'm going to use in my work with my patients, because as you say, you can't expect people to completely change their diet, but if they can shift it to more of those healthier things and less of the unhealthier, then it gives a chance for people to prevent themselves from getting diabetes. And yeah, so grateful. Can I very, very quickly, with apologies to Dr. Paisley, mention that we have got another event that's going to be coming up soon, which is Tuesday, the 15th of March. And we've got a talk on long COVID by Professor Danny Altman. So I think that's going to be another really good event. So thank you so much. Back to you, Jay.
I just say thank you very much for having me as well. It's been a pleasure to do. So thank you.
I'm so glad. Thank you, Angela.
That is a pleasure. Well, all that is left for me is to thank the audience who have been very patient with us tonight and stayed muted all throughout the evening, and the excellent level of interaction and questions that we had from the audience as well. And as we said, there will be another event on the 15th of March. Equally, just as important as this one tonight, talking about the effects of long COVID. And we will have more events in the pipeline that we will inform everyone about in due course. So thank you very much for being here tonight, and good night. Bye-bye.
If anyone is still hanging on and they want to give us a little bit of feedback, we'll be really grateful. But Jay, can you see people?
Yes.
Jay,
go ahead.
Someone's put in the chat, how do we contact members of the committee, and is there a contact number? I'm sure if we gave them Jackie's email or something, you could then distribute anything to everyone.
Yes.
Someone's put in the chat, someone called A6, which I assume is not their proper name. Someone called A6 has put in the chat, how do we contact, is there a contact number, and also how do we contact people, the whole group? So if you'd just like to respond to that.
We are in the act of trying to set up a website for Salford Healthy Communities. So that should be an easier way of people making contact. Sorry,
or maybe
someone
someone,
phone number.
Yeah.
Say that again.
I'll put it in the chat. Hang on.
Okay.
Right.
Okay. Well, one way. We have a few people left who are with us here, and we could just do a show of hands to get some feedback about this evening. One or two questions that we will ask. But first of all, I will end the recording at this stage. After we've asked the questions, and so the first question is, was this event helpful and informative? And if it was, simply either wave your hand or nod your head, and we will have a quick look around. Yes, I think the majority are nodding and agreeing with that particular statement. The second statement is, did it answer most of your questions? Again, simply wave your hands or nod. Yes, I think a very good majority there agreeing with that statement. And the final one, just to keep it brief, is, would you implement some of what you've learned tonight? Yeah. And again, simply nod or wave your hands. That's perfect. I think that's just about everyone for that last one there. Thank you very much.
Oh, that's excellent. So wonderful to hear. That's all we can ask for. If it changes people's way of eating.
Jackie, I thought it was very interesting, and in layman's terms, I've got